Hey everybody, Tuesday night, education night. I clock Epicondylitis patient, treat it from a multi. So, chiropractor, general public, wanting to learn more. Options are site and also at Edlic. I'm going to share my if you could typing into the that way I know that hear me. And hey Paul. All right, Paul. Yeah, let me know if anything happens. I have my phone next to me, and I'm going to turn it on this time, so that way I hear it. If you text me, if something goes a little wonky, because sometimes my internet goes wonky, and I have no choice. Okay, so let's get started. So I'm going to share my screen. All right, looks like I'm sharing, and we'll get going. All right, so this is a little conversation regarding lateral epicondylitis. I like to call a multimodal approach because I don't think there is just one way to treat these things. And I don't think there's just one way to treat pretty much anything that I see in the clinic. We're going to talk about the current evidence. We're going to talk about it from a pain control standpoint, from a protective standpoint, and a strengthening standpoint. So like I mentioned, my name is Cara. I own a clinic in Dallas, Texas, called the Body Lounge, Park Cities. We are a multidisciplinary clinic. I do sports medicine. We have nurse practitioners doing cosmetics and injectables, IV infusions, and vitamin injectables. We have a medically supervised weight loss program. And yeah, that's about it. So we have a lot of fun down here. My PhD is in sports medicine. I'm also a chiropractor, an athletic trainer, and a strength coach. I do a lot of education around blood flow restriction training. I just wrote a couple chapters for the National Academy of Sports Medicine in their new corrective exercise specialist book and program. And so I do like education because it keeps me on top of the current research. And that was kind of the impetus of me doing this, because I had just written the elbow and wrist chapter for NASM. And I was like, man, I learned a lot of stuff from the research that I did for that chapter. And I just kind of want to share it. So let's get started. Where is the lateral epicondyle? I think everybody pretty much knows. But in case you do, it is at the elbow joint. And if we take a closer look, this is looking from the outside. We know that because we can see the radius is right there. The radius is the small bone in the wrist or the forearm, and the ulna is the big bone. That radius kind of floats in there. You can see where the lateral epicondyle is of the humerus. So what this means is that it's crossing the joint. So if within the elbow crease, it's above and on the outside of the elbow. What attaches to that is what's called the common extensors, or the common wrist extensor wad. People will also call that common extensor tendon the wad of 3. And the 3 muscles that are there are the extensor carpi radialis brevis, extensor digitorum, and extensor carpi ulnaris. So these are the three guys that are typically the culprit when we are having that outside elbow pain. When tennis elbow occurs, or what people like to call lateral epicondylitis, we have either damage to the extensor muscle group or what's called a tendinopathy of those tendons. I call it a tendinopathy because research is really indicating, and I'm going to show a couple slides about this, that these are degenerative, they're not inflammatory. So when we say itis, like a tendinitis, that entails, or that makes us think that there's inflammation around the area. And what's common to see now is that that's not the case. There's really not inflammation. It's more about an opathy or a degenerative process. How often is this prevalent? About 1/3 of all elbow, forearm, and wrist injuries account for 1/3 of workday illness. The entire population, about 1 to 3%, walks around with tennis elbow, and about every out of 1,000 visits to the primary care physicians, 7 of those are for lateral epicondylitis. What is it? It is a common tendon injury. It's typically an overuse injury. We don't give the tendons enough time to rest between activities, meaning I play tennis today and tomorrow and the third day. The tendon gets tired, gets exercise-induced muscle damage, and breaks down, and we keep adding more and more breakdown to that tendon until the tendon degrades. A lot of times I see very poor form contributes to this. It doesn't have to be just for tendon players, or tennis players. It can be all different types of people come into my clinic that have this tendinopathy. Can be workers, can be people that use a screwdriver a lot, can be people that use a hammer. Anytime that you're using those wrist extensors, it can be part of the issue. People that know me, I think about injuries as this capacity versus demand, or capacity versus tolerance. So let me take you through this chart. Here is the demand. This is this red or this green line. This is the demand that we're implying to the tissue. This dotted red line is capacity. That's how much our tissue can tolerate. And when we have injuries, that means that the demand has exceeded the capacity, which then drops our capacity due to that injury. So again, injury occurs when demand exceeds capacity. If we're trying to do something and we want to continue to do it, but that activity continues to injure us, we have two choices. We can either reduce the activity that we're doing, or we can increase the capacity through strengthening. Most of the time in my clinic, it's about having to strengthen tissue to tolerate the activities of either daily life or physical demands that we're applying to it. Now, this is a very important concept, because what I found from my research and what I've really believed for a long time now is that it's not just an elbow issue. It is a issue that can be either at the wrist, like there's a problem at the wrist, or it can be at the shoulder, it can be at the scapula, or it can be at the neck. So it's really, really important for us to not only differentially diagnose it's a lateral epicondylitis, but why are the demands exceeding the capacity at the elbow? Because really what the elbow is just an intermediary between the wrist and the shoulder. And it absorbs a lot of energy because a lot of movements that occur at the wrist, the forces have to be dissipated through the elbow, then goes up to the shoulder, and then to the scapula. So we want to be sure that when we are looking at these things, that the problem is truly an elbow problem, and it is not a secondary neck issue or a mobility issue at the shoulder or a stability problem at the scapula. Now, Thomas Myers has written a book called Anatomy Trains. That's where I pulled this reference from. And this is the interconnection of tissue, both at the neck, scapula, through the shoulder. And it's what I want everybody to take home from this slide is it's all connected. We can't look at just the elbow to treat these things. These things are too hard to treat, and we need some help with them if we're going to get them to resolve so we can get people to be active. Another concept that is talked about is called a regional interdependence concept. And I found this a lot showing up with when I was doing my research for the NASM chapter. What it was is that people were doing treatment just to the neck or just to the shoulder or just to the thoracic spine and finding benefits at the elbow. So it's really imperative that we look beyond just the elbow when we're treating this, because we'll miss it if we do a lot of the times. I mentioned the term tendinopathy, and it's preferred to tendinitis because of the presence of a disordered and degenerative healing process, not inflammation in the pathogenic tendon. In order for us to truly heal this tendon, we need to change the way that degenerative healing or degeneration has occurred. And a lot of times we need to do things like bring blood flow to the area. Bringing blood flow, stressing the tissue with exercise is what gives us long-term healing and return to activity. I like to tell patients that these things become like a frayed rope. The rope is no longer fully intact. You've got these little frays that are coming off of it, and that needs to be regenerated with exercise and also things to bring blood flow to the area, which I'll talk about. According to Dr. Kane, he says the mainstays of initial treatment for tendinopathy are activity modification, relative rest, pain control, rehabilitative exercise, and protection. So we're going to talk about a lot of these things. And it's also important to understand that treatment can take up to 6 months for a full resolution of a tendinopathy. And that could be a tendinopathy at the Achilles tendon, patellar tendon, lateral epicondylitis, medial epicondylitis, rotator cuff. It can be any tendon in the body, really. And the reason is because these things do not get good blood flow, and we need to bring blood flow to the area so it can heal, unlike a muscle that has really good blood flow and is a lot easier to heal. So the way I'm going to do this presentation tonight is looking at a chart that I just made, and I've been pondering trying to make this chart for a long time. And so what I want to describe is what exercises and what type of modalities and things do we do based on the pain scale. So a pain scale is typically done on a 0 being no pain, 10 being childbirth, kidney stone, very extreme pain. And so if we start off of it at a 10 pain, this typically is emergency room type pain. Like this is non-tolerable pain. And then it goes down from there, and hopefully over time, this gets to be less and less and less. Now, this little blip is a flare-up, because what happens is we get down to levels of pain that are pretty tolerable, like a 3, and we start to do more activity than usually what we can tolerate. And what happens is we get a little flare-up. So the pain temporarily blips up, and then we get a little bit better, and then the pain temporarily blips up from a little bit of overuse again, and it happens again. And then eventually it kind of smooths out and either fully goes away or maintains a very low level. So this is kind of this ideal pain reduction over time. This could be a week, this could be 2 weeks, this could be a month, this could be a year. It just really depends on the injury. But I just wanted to put a kind of graphical representation, because I'm going to lay some other things on top of this to help describe kind of my thought process when it comes to treating these things. So now what I'm doing is I'm breaking this up, and I'm saying, okay, well, when I'm at a 10 pain, I'm sending patients to the hospital to get medication and probably some morphine or something. And that's going to maintain until they're about a 7. From a 7 till a 5 is kind of this difference between passive threshold to active threshold. Once people get to a 5, I feel like we need to be initiating active therapy in the form of exercise. So other things can happen to get pain levels down. That can be ice, that can be electric stim, that can be a lot of different modalities out there to try to address pain. But once we kind of get into this 5 range, we really need to be doing active therapy in order to regenerate the tissue. So This is a nice description, I think. You please let me know in the comments if this makes sense, but we're going to break this down into like, hey, from 10 to 7, and then 7 to 5, and then 5 to 3-ish, and then from 3 till 1, and then 1 on, what kind of exercises and things are we going to do? So when we're in that high pain threshold or that high pain tolerance, typically we need some medications to help us. Anytime we're above a 7, that's too much pain. So I recommend to patients that we either do an injection or they get some pain meds from their primary care physician to get that pain under control. Now, looking at the literature, we have to understand that there are some risks associated with that. When I use a corticosteroid to get pain levels down, remember, there's not inflammation in those tendons typically. It's a tendinopathy, not an itis. And so, yes, it does help it temporarily, but it's exactly that. It's temporary. What seems to be better long-term is PRP, platelet-rich plasma. And that's where we take blood, we spin it in a centrifuge, we take the platelet-rich plasma away from the platelet-poor plasma, and it's a very clear liquid, and we inject that into the area. And again, that's bringing blood flow or oxygenation to the area for natural healing. And the problem with these things is that we can't be active with these for probably at least 2 to 4 weeks. If I do a PRP injection, you're about 4 weeks before you can really start to do much with it, because otherwise it just won't work. There's too much activity in the tissue. So just keep that in mind. The other thing that I want people to be aware of is the risk associated with corticosteroid use is further degeneration of the tissue. And so we only want to use that in short term when pain is just too much. Like we just can't sleep, we can't do anything, we can't eat, we can't pick up our kids. And so we're going to use that in a very temporary, short term, one time only modality to try to get pain levels down. There's some other things that we can do to bring blood flow to it besides injection and besides, basically besides injection. And one of those is dry needling. I used to use dry needling a lot with these things. I still use it on occasion because you can cause little micro bleeding into the area. Dry needling is using acupuncture needles, and there's been some decent research demonstrating that it can be effective. Currently, I'm using mostly shockwave therapy, and the reason I use shockwave therapy is that I just get much better results. In addition, it's the reason that I purchased the shockwave therapy for my clinic was because the research backs it very well. And so, what shockwave therapy really is, it's basically good for regenerating bone. It's good for regenerating tendons, other musculoskeletal disorders. It's also good for aesthetics. We can use it for blood flow for areas like cellulite. And it's also good for men's health for blood flow for erectile dysfunction. You may know shockwave as extracorporeal shockwave therapy. You can see it abbreviated as ESWT, extracorporeal, and then SWT, shockwave therapy. Sound wave or acoustic wave. I prefer using sound wave because people don't really like to hear the term shockwave. It's really nice for pain management as well. I can start at about a 7 out of 10 pain and not only start treating the tissue, but also bringing blood flow and decreasing pain at the same time. It really helps us to bridge the gap to allow more exercise or loading. It stimulates healing and attracts additional cells capable of inducing healing to the injured area. It's also a mechanical stimulus, so it causes strain, kind of like exercise does, that causes a biological response for healing. There's a mechanical force at the cellular level, and it helps to revascularize tissue. Biologically, it helps to eliminate and reduce pain, increases circulation and metabolism, stimulates neovascularization, stimulates tissue and bone growth. Lots of other things that can occur. Reduces muscle tension, which I'll show. It typically takes about 3 to 5 treatments. I generally like to treat those 5 days apart. We use coupling gel. We do about 3,000 pulses in each treatment area. Patients tell me where those treatment areas are needed to be because those are the areas of pain and areas of degeneration. I can typically start this at least at a 5, but up to a 7 out of 10 based on the patient's tolerance. And again, I'm going to treat the tendon and also the associated muscle group. So here is me treating the tendon itself. Here you can see me using this white tip. This white tip is used in areas of bone, less energy, or the energy gets dissipated a little differently. So I can, it's not so intense. That X marks the spot right on the lateral epicondyle. So I would do this directly on the tendons as they're inserting into the bone to help regenerate the tissue. Then I switch it to a ceramic tip. The ceramic tip is a little more intense. It sends the energy a little bit more focused, and I can send that directly into the tissue that's associated, those extensor muscles. So you see me going all the way down towards the wrist. I don't typically go into the wrist bones themselves, but I'll stay within the muscle belly. What really is making sure that it is a tendon issue is part of that proper patient selection. Knowing that you got to do the 3 to 5 sessions to really get this to heal right. And the maximum benefit is really seen at 12 weeks. So although we do 3 to 5 sessions to get pain levels down and get moving, we're going to see the benefit all the way up to 12 weeks, which is what we're going to supplement with heavy loading. I'm going to kind of talk about how we kind of incorporate that. Research for using shockwave therapy with elbow pain, about 77% improvement, which is really good. And then other things in there that show improvement. So let's look at that chart again. And I broke down this chart. We've got this passive threshold. So once we get pain levels down, however we're going to do that, whether that's with rest or ice or medication or injection, now we get to that 7. Now I'm going to start using that shockwave therapy to start reducing the pain further in conjunction with other modalities. That could be e-stim, that could be ice, that could be other things, anti-inflammatory drugs, Tylenol. Then we get to that 5, and we want to start introducing some exercise at this point. Now, what exercises can we do? And so let me kind of go through this. In this phase, we can do exercises, but we probably don't want to do exercises to the specific tissue. So we do something called reciprocal inhibition. Reciprocal inhibition means I activate the opposite side of the muscle or the antagonist. So if we're treating wrist extensors, I would exercise wrist flexors with reciprocal inhibition. Then as they get better and as the pain levels are dropping, then I can switch into light stretching. I think one of the common misnomers that is misunderstood is that stretching alone causes stress to tissue. So we can't just stretch tissue. We have to do it methodically and not too aggressively. Otherwise, we'll irritate tissue. They've actually seen muscle growth just with stretching. They attached weights to wings of birds and let it hang there for long periods of time, and they saw hypertrophy or muscle growth occur. So we know just putting stress on tissue will cause muscle growth. So we use that as part of our rehab process. So once we get to a certain pain level, about a 3, now I can start doing more like isometric type work where we're not moving the tissue at all. And what my goal is not to get people above a 5 out of 10. So if I start doing isometric work and it brings them above a 5 out of 10, I've got to back off and go to the step before. After isometric work, then I go to isotonic work. And isotonic work is both flexion and extension, or eccentric and concentric exercise. My normal like bicep curl, doing both up and down movements. And then once I get down into this mode here, I really want to start hitting eccentrics heavy. Eccentric is just the lengthening exercise, and I'm going to show examples of this. And it's been demonstrated to help regenerate the tendons even further. So once pain levels are low, like a 0.1, 0.2, even up to about a 1, then I can start hitting them with heavy eccentrics. So here are my exercise choices: reciprocal inhibition, stretching, isometrics, isotonics, both concentric and eccentric, and then dynamic type movements if I can get there. So here's an example of reciprocal inhibition. I'm just stretching, basically, working the wrist flexors without weights, stretching and flexing the wrist flexors. And I might do 10 reps 4 times a day. You notice I'm not using any weight here. I'm just trying to activate the muscles on the opposite side of the injured tissue. Here's an example of just stretching. I'm pulling my wrist down, so I'm stretching the tissue. And I might do 30 to 60 seconds 4 times a day, but I'm going to do it very, very, very light. Like this is light. Like I can barely feel a stretch when I'm doing this. So don't overdo it. Otherwise you'll irritate the tissue further. If I'm doing this stretching and it brings my pain above a 5 out of 10, I've got to back off of it and do something less. Now, when we're doing light load, when people are still in pain, there is not going to be much physiological adaptation, if any, because the loads are not heavy enough. So I do something called blood flow restriction training. So here is my patient, and you can see she's got a cuff on her upper limb. And that cuff is inflated to a point where I'm only allowing a little bit amount of blood flow in, and I'm not allowing any venous return out. And what this does is it makes this exercise much, much more difficult. I keep her wrist totally stiff. And if you notice, her elbow is totally extended. The reason I have the elbow extended is because I'm trying to get the muscles that are crossing the joint. So these muscles of the wrist extensors cross this joint, they cross this joint, and to maximally tax them, I've got to have full extension here and full extension here. So with BFR isometrics in the clinic, we do 1 to 2 minute holds for 3 rounds with a 1 minute break, up to a 1 minute break in between. And here I'm just stressing the tissue, trying to get it tired. Then I'm going to do BFR isotonics. So this might be a week or 2 later, but just remember my chart. And here I have the cuff inflated, and now she's doing shortening of the tissue by concentrically loading and then lengthening the tissue with eccentric. So these are slow and controlled, 2 seconds up, no hold, 2 seconds down, no hold, 30 repetitions with a very light weight, 30-second rest between, 15 reps, 30-second rest, 15 reps, 30-second rest, 15 reps, 30-second rest, and then I deflate the cuff. And then she probably will only need that while she's in the clinic. Then after maybe a couple weeks of that, I go to heavy eccentrics. Again, this is when the pain levels are very low. And I do only the lengthening component. So he's lifting the weight. The elbow is totally straight and just slowly lowering the weight and then dropping it. And what this is doing is eccentrically loading it in order to get that eccentric load. Now, prior to him doing this, I did a BFR protocol, which reduced the amount of blood flow into the limb, and it's called ischemic preconditioning. And that ischemic preconditioning has been shown to decrease the amount of damage that's occurring during exercise, and that's why I do it. For protection, we use elbow braces. I really like this elbow brace called an air cast. We use it 2 finger widths below the elbow joint, and I tighten it to the point where I reduce the amount of discomfort when I test the elbow or wrist extensors. And then I also have people buy hand straps so they don't have to grip so hard when they're lifting weights to reduce the tension on the wrist extensors while they're rehabbing. So that's the protection component. If you want to learn more about shockwave or sound wave, you can call Bob or Paul. You can email them, or you can send me an email. I'll be happy to answer it. And then now I'll just kind of do a question and answer. And you can type any question into the comments bar, and I will answer them now. Okay, so Matt's asking me, what tip do I use? So the tip on the shockwave, is that what you're talking about, Matt? Oh, I already answered. Okay, great. All right, thanks. Sorry, I don't see the comments while I'm presenting. So I like using the ceramic tip through the muscle, and I like using the plastic tip on bone or bone fractures. So I'll do that on a metatarsal fracture. I'll do it on fibular fractures. I'll do it any fracture that I can get to that's not fully casted. I get great results with that, by the way, too. A Therabar, yeah, a Therabar you could do as well. You're going to be doing that kind of that twisting motion. I'm assuming that kind of that loading. Yeah, I think it's good. I think anything in order to load, as long as we don't get above a 5 out of 10, because otherwise that's going to inflame the tissue and irritate it. I'm trying to give a kind of a step-by-step process for the progression of therapeutic exercise, with understanding that the research shows heavy loading eccentrically is probably going to give us our best bet. And then once you're able to do that, then we progress to just regular heavy loading. But we got to make sure that the pain levels are down. Any other questions for me about the presentation or anything else? I kind of cut it a little bit short. I had a couple slides on the on looking at the shoulder, making sure you're looking at the neck for any type of radiculopathy. I look at the elbow and make sure that the ulna and the radius are moving well and functioning well. Otherwise, I will manipulate those. Matt asked me a question, what type of cuffs do I like? Yes, I use the Smart Cuff because it is FDA listed. It's wide and they get good efficacy, and you can get full occlusion. I need the full occlusion for ischemic preconditioning, and all other cuffs except for the Delphi cuff, you really can't get that with. So that's why I like the Smart Cuff. Any other questions for me tonight? I really appreciate everybody attending. I know it's late. You've already probably been in clinic all day. I like to do these about once a month. I don't know what I'm going to do next month's on. If you have any recommendations, if there's other things you'd like to see. Mark was wondering PRP versus pulse wave. I think you could, it really depends. I like to go pulse wave unless it fails. And if it fails, it typically means that the tendon is too degenerated. There's too much tear in there. And so I will reserve PRP for after an MRI. So let's say I do 3 to 5 sessions with the pulse wave and it does not get any better at all. Like there's no change over the course of 3 visits. Now I normally see change after 1 visit. I normally get improvement right away. It's just not fully resolved. If I don't see any change or things get worse, I'm getting the MRI. MRI shows a large tear or a tear large enough that I don't think is going to heal. Then I will go PRP prior to surgery. So then I might do PRP, kind of rest it, not do too much with it for 2 to 4 weeks. And then I would kind of reinstigate the tissue with the sound wave or the shock wave or pulse wave, however you want to call it. That's very rare though. I very, very rarely, 1 out of 50 would actually end up getting to MR, because most of the time I'm getting these things resolved very quick. Any other questions? So please send me an email, give me some feedback. I like to do these, every month for a different condition. If there's any recommendations on what the next condition should be, or, you like to see different protocols, other things. I like to listen to what other people are needing and wanting. And it makes me do a little bit of research too, to see what's currently out there, because as we get into clinic, we sometimes forget, and we don't go to the literature very often unless we're kind of forced to, because we're just busy. Am I going to post these to YouTube? Yes, sir. My YouTube channel is just Ed Cara, simple. And I will post these to YouTube after I edit them and make sure that they're good. And I got a little branding and stuff. Yeah, that's it. All right, you guys, thanks so much again. Look out for next month's, I don't know what I'll talk about. Maybe I'll talk about Achilles tendinopathy or something. I've been kind of into tendons lately. I think they're super interesting. They require a little bit more work. They're tough. They're just hard to treat, long-term and get people back to activity. All right. Thank you very much. I am out.